Dr. Robert P. Griggs, and he has a very extensive resume, so I'm going to summarize a little. So basically, Dr. Robert Griggs joined the Department of Obstetrics and Gynecology at the National University Health Medical Center in August of 2017. He currently serves as Director of Obstetrics and directly responsible for the training and training of 16 residents at the residency training program. Dr. Griggs received his undergraduate training at Cornell University, graduating with an AB in mathematics, and received his medical degree from the State University of New York at Buffalo. He completed 1 year of general surgery at National University Medical Center before going on to complete his residency in obstetrics and gynecology at the Lutheran Medical Center. I'm not sure if I pronounced it correctly. Medical Center in Brooklyn, New York. After completing his postgraduate training, Dr. Griggs went into private practice and has been practicing in the East Meadow community for the past 29 years. Dr. Griggs is board certified in obstetrics and gynecology and brings a wealth of clinical experience to the Department of Obstetrics and Gynecology. He currently practices at a practice within the hospital that is open to the entire community. Dr. Griggs practices in the hospital with expertise in ambulatory care, operative laparoscopy, excuse me, I was not able to pronounce that, minimally invasive surgery, infertility, and gynecological oncology. Dr. Griggs is a clinical assistant professor at the Donald and Barbara Zucker School of Medicine at Hofstra University and actively engaged in the teaching of residents and medical students. Okay, what I'm going to do is I'm going to summarize the rest for obvious reasons. Dr. Griggs is also an honorary police sergeant for the New York City Police Department and the PBS surgeon at the New York State Troopers report. His complete bio is available on our website. So without further ado, I'm going to introduce the good doctor. Thank you, sir.
Thank you for that beautiful introduction. I'm just going to kind of shave it over a little bit. To tell you a little bit about myself. So I grew up out in Long Island, all the way in Patchogue, Long Island. Went upstate, by the way, to train. Cornell University is where I pursued my undergraduate training. Graduated with a degree in mathematics. Went to State University of New York at Buffalo and did my medical school there. Came back to Long Island. This is where my family grew up. And been practicing actually in the East Meadow area now for like the last 28 years. I was engaged in private practice, and being engaged in private practice, I think, kind of gives me like a little edge in terms of talking about how quality of medicine is, in terms of how medicine has changed, how quality has changed, how, for the most part, providers interact with the insurance, how providers interact with the insurance companies. When I first started out and I joined the senior partner. I've been, by the way, in practice for over 30 years. So essentially what most practitioners did, you joined a senior partner, you worked for about 4 to 5 years, you became a percentage partner, and slowly but surely, you, for the most part, took over the practice. Fortunately enough, that's changed a lot now for residents and medical students who are entering into postgraduate education. As a result, approximately 2 years ago, I was approached by the hospital to become the director of obstetrics. So now I kind of transitioned my practice to the hospital. I have a private practice actually in the hospital, on the hospital grounds. It's the first time that we have something it's the first time in the history of that hospital that we have a private practice actually in the hospital. So it's a new concept, as opposed to physicians just selling their practices. In addition to that, I train residents. I have 16 residents, by the way, under training, and these are residents who, for the most part, are going to be graduating and going into private practice in the seemingly couple of years. So just give a little speech about quality in medicine. That's what's interesting. So the Institutes of Medicine, they, for the most part, define quality, healthcare quality, the degree to which healthcare services of individuals and they increase the likelihood of desired health outcomes. For the most part, what we're referring to is maintenance of life, maintenance of quality of life. And also that's consistent with standards of evidence-based practice. That's something now that physicians, practitioners, whether they be nurses, whether they be physicians, are all, for the most part, concerned about. We have to practice medicine now with evidence-based outcomes, because that's what the carriers, that's what patients expect, and that's what the carriers expect as well. In order to measure quality, we have to have certain indicators. These are the quality indicators, or sometimes they're referred to as like domains. Domains, by the way, that carriers and healthcare organizations, quality assurance corporations look for, and how the patient's being treated, in addition to which, how, for the most part, how effective is a provider, in providing care. We're looking for effectiveness. In other words, the care that the providers is, for the most part, giving supports, by the way, evidence-based scientific medicine. Is it efficient? Is it delivered, by the way, in a fashion where patients, by the way, are satisfied? Is it equitable? Is it care that's not just necessarily affordable for those who can afford it, but for patients who can't afford it? Is it patient-centered? Is it, for the most part, deemed to educating patients and meeting support services? Is it timely? Care is not, for the most part, beneficial unless it's delivered when the patient needs it. And more so, what's really concerning today is safety in care. That's what's driving the hospitals. Anybody who's had an interaction with a hospital, an ambulatory care setting, whether it's a doctor's office for a colonoscopy, whether it's a cataract for an ambulatory setting, everybody knows about safety. We want to minimize potential actual bodily harm to the patient. These two quality organizations are the ones who, for the most part, oversee the entire healthcare organization. Centers for Medicare and Medicaid Services. They oversee the majority of the federal healthcare programs. They administer the Medicare, which we all at some point in time will be on. They partner with state governments to administer the Medicaid program, for patients who have disabilities, or patients who from lower income. They also, most importantly, monitor health information technology. Your physicians, I'm sure, if you go to your doctors today, most of the time, your doctor, typically when I first started, I walked in the room with a chart, started writing. Not anymore. Now when I walk into a room with a patient, I'm carrying a tablet. And that tablet, by the way, I can check off, by the way, what I need to know about the patient. Hopefully, that's going to let the patient know, hey, listen, I'm listening to their concerns. At the same time, it's going to allow me to get information that's important. All that information that's being collected, makes data. The Joint Commission, that's the organization that goes from hospital to hospital, and for the most part, what they do, they survey and they critique hospitals. That was the organization that I was telling you that I was involved in a couple of weeks ago. And hospitals, just like other organizations, we have to prepare for that. We have to make sure, by the way, that our standards are up to snuff, because what ends up happening, if not, we get citations. And those citations, by the way, can inspect patient care. Those citations that by impacting patient care, it also impacts revenue streams, and our bottom line as well. National Committee for Quality Assurance. They generate probably the most important information data set. It's called the Healthcare Effectiveness Data Information Set. That's HEDIS. HEDIS, by the way, tracks significant trends in public health issues, chronic diseases such as cancer, heart disease, smoking, asthma, diabetes. It also gives your employers the opportunity to reliably compare from plan to plan. So this way, what happens? Your employer can determine which plan is going to be best for their employees, which plans are not going to be so good for their employees. In addition to that, there's a lot of other entities that are now tracking quality. No matter what physicians do, no matter what nurses, dietitians, pharmacists do, there's always someone now looking over our shoulder, telling us, not necessarily telling us, but kind of convincing us or kind of tracking what we do. That information is all taken, and again, it makes data. Just more so at the bottom, state regulatory agencies, licensing boards. Not that they're sort of like newer to, for the most part, tracking the quality game. Physicians who, for the most part, serve on the licensing boards. Again, are interested in maintaining quality. State departments of health, National Practitioner Data Bank, any physician who's ever, for the most part, who's had a malpractice suit. Their names are listed in that National Practitioner Data Bank. Yes. Getting back, the National Practitioner Data Bank. Everyone, by the way, has the access now to computers, to the internet, social media. You can find out anything about any practitioner these days. How many malpractice suits they've had, how many suits they're currently involved in. Patient, for the most part, evaluations. How friendly is the patient? How friendly is the physician? In addition to which, you can also go on insurance websites, and these insurances now provide grades on physicians, whether or not the physician, by the way, conforms to standards of care, whether or not the physician, for the most part, meets their expectations. These same expectations, by the way, that the insurance carriers, HMOs, and private health organizations make, also determined by how much the practitioner is going to be paid. Malpractice carriers are also kind of new to the game. Obviously, hey, listen, they don't want physicians or providers who, for the most part, are either injuring patients or, for the most part, pose a potential injury for patients. So this is where the origin of all our healthcare quality data comes from. Most importantly, the electronic medical records, administrative data, enrollment eligibility, enrollment forms, hospital discharge data. Anyone who's discharged from the hospital, all that data, how long they were in the hospital for, procedures they had, what their responses were to the procedure, what discharge medications they were on. All of these are tracked. Insurance claims, inpatient, outpatient, pharmacy insurance claims. Patient disease registries are more so for chronic conditions. Now, if I discharge a patient who's treated for cervical cancer, what ends up happening is about 2 to 3 months later, the insurance company sends me a form, DrGriggs, they listen, what's going on with the patient, is she involved in care? They, for the most part, like me to send them back some sort of documentation. National healthcare surveys, countrywide surveys, by the way, that determine status and quality of health. Clinical trials, registries, and databases, more so for patients who have complex, for the most part, complex diseases. We're talking about cancer and chronic conditions. Why is quality important? Well, you got to think about the consumer. The consumer of quality in healthcare is the patient. You want to make sure the patient has a good experience. It also supports clinical data for evidence-based practice. That's where it's going. Anyone who's in the medical field is going to know, hey, listen, now it's evidence-based medicine. They've replaced, by the way, doctors don't have the liberty anymore of just doing what they want or treating patients the way they want. They practice by a set of guidelines, a set of, for the most part, practice parameters that, for the most part, have been shown to work for different conditions. Also highlights areas for improvement in best resource utilization. Most importantly, also enables, by the way, us to track trend, outcomes, and effectiveness of treatment patterns. Most importantly, it also builds trust and engages patients in the delivery process. A lot of patients these days, my patients including, they feel disconnected from their physicians for a lot. They go into, for the most part, he listens to the physician's office. A lot of times, my patients will tell me, Dr. Griggs, the physician never looked at me. He was looking at his tablet the entire time. Decreases in attitude disparity. Different patients of different socioeconomic levels, obviously, for the most part, even though it's sad to say, experiencing different levels of care. Accelerates reduction in morbidity and mortality. That's the whole, for the most part, the concept behind quality, is that we want to decrease mortality, we want to decrease morbidity, we want to make sure, by the way, patients remain more functional, patients have more quality of life, and it strengthens overall healthcare delivery systems. Quality as it relates to outcomes. Okay. Providers generally, when I'm treating a patient, we're all guilty. We try to focus on measures we can control. Which antibiotic the patient was on, how long they're in the hospital, how long their surgery took, what was their post-operative course, how soon do they get up after the hysterectomy, how soon do they get up after the cesarean section. Okay. Quality, however, patients, by the way, look at different, for the most part, aspects of quality. And that's now where quality is going. We want patients to be satisfied. We want them to be, for the most part, less anxious, less stressed about their care. So patients are more concerned about How soon can they get back to maintenance of normal function? Was their pain relieved? Okay. How soon were they able to return to work? Or time, for the most part, when they entered the healthcare system, the time they wanted treatment, and the duration of time before they get to work. Most importantly, again, reduction in diagnostic complications do happen. As you know, as more and more patients enter the healthcare system, we know, by the way, listen, we want to, for the most part, decrease those complications. We want to decrease the diagnostic areas, and in addition to which, a decreased patient anxiety. These are the list of quality performance measures, Joint Commission. These are the list of what they've determined to be very important quality measures to, for the most part, study right, standards for maternal safety. New York State, Governor Cuomo, just for the most part, we're seeing it. At my hospital, we serve a lot of, for the most part, indigent patients. These are patients who don't have insurance. So we see a lot of something called preeclampsia, which is high blood pressure in pregnancy. We see, in addition to that, we see complications of preeclampsia, anywhere from high blood pressure, seizures, to neonatal morbidity. So Governor Cuomo, just for the most part, started this new committee to study that. Why is it, by the way, that some patients, by the way, are prone to this preeclampsia development, and some patients aren't? Is it a factor, by the way, of their diet? Is it a factor of their social environment? Is it a factor, for the most part, is in their education? Antimicrobial stewardship, ambulatory healthcare settings. Physicians prescribe antibiotics. We have a new load of antibiotics, by the way, that are on the market, that are flooding the market. Not necessarily everyone needs an antibiotic. So now, by the way, stewardship. Our hospital has an active committee that, for the most part, tells the physician, hey, listen, if you have this type of infection, this is what you should be using. Doctors aren't capable of just prescribing any antibiotic they want. Okay, if you want a high-level antibiotic, we call it 3rd or 4th generation cephalosporin, you have to get a approval from something called the Infectious Disease Committee. Pain assessment and management standards. Now, everybody knows about the opioid abuse. Opioid abuse is rampant. There are some hospitals now, physicians aren't capable. I have a friend who's practicing emergency medicine out in Michigan, and in his hospital what happens is doctors are only allowed to write for opioids in the morning. So supposedly, doctors, by the way, doctors will write for more number of opioids when they're tired and at the end of the day. So the only way you can write an opioid, an excessive amount of opioids for a patient is that you get an approval. How outcomes influence providers? Well, these outcomes are being collected. They're reported publicly. You can take a look at them. You can see how I am as a physician. Reputation. Outcomes result in providers facing increasing scrutiny and pressure in clinical practice from third-party payers, which means, by the way, listen, the insurance companies, by the way, base the reimbursement to particular doctors based on how they perform for their measures. And they provide incentives. Sometimes those incentives can be positive, sometimes those incentives can be negative. To adopt their own best practice, I like to call them different practices. Promotes competition among and between specialties. I don't know if that's so good all the time. Providers respond. Providers can either comply or they can withdraw from the system. Quality relates to safety. In order to achieve quality health care, it's got to be safe. Practices which improve patient safety improve the overall quality of care. If you walk in Nassau County, the first thing you're going to see is how safe the hospitals. You see in most hospitals, you see how safe the hospital, what they're doing, safety initiatives. It aims to identify points along the delivery chain where vulnerabilities are more likely to occur. In my hospital, when I'm on call in a labor and delivery suite with my residents, first thing we do, there's a shift by the way going off, my shift is coming on. Every patient is, by the way, discussed. Even if we discuss the patient, by the way, like 30 minutes ago, every patient is discussed, just like a new management plan. We have something what we call huddles, by the way, with for the most part, nursing care. Every time there's an intervention, whether or not it's a deceleration in fetal heart rate, whether or not, by the way, the patient's bleeding, whether or not I take a patient back for an emergency cesarean section. And allows, by the way, the physicians, hospitals, committees, and hospitals to adopt contingency plans. But we know errors most likely will occur, but we have to be able to deal with those errors right away. The question becomes, as all these initiatives increase in number, with the increase in scrutiny, will this delay care? Quality relates to cost. This is something, by the way, that's very important. Like every marketable product, healthcare is now becoming a product. and how well that product is delivered, and how well patients are satisfied, how well consumers are satisfied with that product, drives the overall system. Payers are aggressively reducing reimbursement. Payers are transitioning from a fee-for-service model where basically your doctor, you had an interaction with your physician submitted a bill, you submit the bill to the insurance company pays you. That's no longer happening. Most payers are now trending toward this performance-based reimbursement. Performance-based reimbursement, you did a colon resection, patient should be in the hospital for 3 days. They should be up the first day, have a bowel movement the second day, out of the hospital by the third day. That's what they want to see. If your patient stays in the hospital, complication not necessarily of your own. Patient, by the way, has an ileus or bowels for the most part distended, haven't had bowels out. That, by the way, will cost you. You do another of those things, if you're a GI surgeon, you do a number of those, you have patients who stay in the hospital for a prolonged period of time, that's going to affect your reimbursement, that's going to affect your bottom line. Increasing percentage of patients are covered by third-party payers. Everyone's got insurance. So believe it or not, everybody now is a willing, or not so willing, participant in the game. Now, there are tiers of players. Third-party payers, insurers, those are commercial private malpractice carriers, administrators, CEOs, hospital administrators, the providers, MDs, RNs, middle, anyone who takes care of the patient. And lastly, we see on the list is where the patient is. Third-party payers. They're the ones who pay the claims on behalf of the insured. These represent all type of federal government agencies, employers. They have to provide care and insurance comes to a large number of their insured. So they have, by the way, an increased struggle to keep their costs down in order for the company to remain viable, remain profitable. Most of the time, insurances, by the way, don't even get to pay 80% of the patient's bill. So now insurances are engaging in what they call cost sharing. Cost sharing is where they provide initiatives for preventive care. You go, patients, a patient who needs a mammography, she goes to the hospital, has a mammography, hey, listen, she'll get an additional $30 reduction in her insurance bill. Value-based healthcare benefits, performance-based methods. These are all the different, for the most part, players. The patients, the providers, the payers, the suppliers, your drugs, society. What society thinks, by the way, about healthcare. Are they utilizing healthcare, by the way, effectively? Is, by the way, hey, listen, the insurance companies, for the most part, responsible for what they're doing. This is where the healthcare dollar goes. If you look very quickly, prescription drugs. That's where most of your healthcare dollars are going today. New prescription drugs. Doctor services, direct relief, office and clinic visits, hospital stays and taxes. At the bottom of the list, as you can see, minimal for the most part goes to finance, claims, special investigations, care management. Skyrocketing cost of pharmaceuticals. This, I have a mother-in-law right now who, for the most part, has Medicare. We are currently, by the way, trying to transition over to nursing. I was not aware, by the way, how much medications cost. She's paying over $1,200 to $1,500 per month for medication. It's ludicrous. And pharmaceutical companies, something's got to be done. Doctors, by the way, hey, listen, doctors are frustrated. Patients are frustrated. How is it possible, by the way, you pay into a healthcare system like the United States, and for the most part, hey, listen, you get to a certain age, hey, listen, you are, for the most part, hey, listen, your entire nest egg is, for the most part, depleted because you have to pay for care and you pay for your drugs. Healthcare administrators, these are, by the way, they're responsible for the board of directors. They have to ensure prosperity of care. Don't forget, they insure thousands of patients. They have to oversee policy and cost containment strategies. Healthcare CEOs make an average of $18 million annually. You may say, well, doctor, why were you a doctor? You should have become a healthcare CEO. It wasn't like this, naturally. When I first walked in, I mean, just a lot of my friends now, they're becoming, for the most part, taking administrative courses. Healthcare CEOs made a total of $1.1 billion in 2018. That's more than $157 million in the CDC spent on chronic disease prevention. When you think about that number, that's amazing. In addition to which, Americans spend about $88 billion annually to pay for debt, medical debt. 1 in 5 Americans struggle with medical bills or debt. So salaries, and when I came across this slide, I had to put it in. And as a physician who, for the most part, hey, listen, You have the scrutiny from the insurance companies. You have, by the way, I'm on the phone all the time, for the most part, trying to get coverage for my patients. When I take a look at this, it kind of frustrates you. And really, for the most part, how's the system geared toward that? Providers, physicians, nurses, mid-level practitioners, those are your PAs, your nurse practitioners. They're facing an increasing number of third-party constraints. They're being asked to justify what they do. You can no longer be a doctor. You have to justify. A lot of times, I'm on the phone with someone who's not even a physician. They're reading from a picked list, by the way, of questions. And depending upon what I answer, they're going to trip me, by the way, to the medical director. So providers will find themselves, they're less independent in the provision of care. Myself, coming from a private practice, where basically you were in control. Now working in the hospital, you kind of see where it's kind of different. You're not necessarily in control. Care is being dictated by the insurance carrier. Rising office expenses inevitably lead to decreased compensation for all providers, not just for physicians. These are the challenges, by the way, that your doctors face now. When you see your doctor, this is what he's dealing with. Less reimbursement, cost of his staff, cost of his supplies are rising. ICD-10, that's what we use, by the way, to bill patient encounters. The doctor submits a bill, by the way, to the insurance company, and hey, listen, it's not what they call a clean or scrub bill. That bill gets shot back. Your provider's got to take time, he's got to have people. He's got to have people, by the way, billers, who for the most part know how to correct the bill. Resubmit the bill. That bill's not submitted, by the way, within a designated period of time, usually anywhere from 30 to 90 days. What happens? He doesn't get paid for it. So he loses that. He eats that. Okay? EHR, electronic health records. Physicians are now being capitated. If they don't have electronic medical health records, okay, for meaningful use, which means, by the way, listen, they've conformed to certain, for the most part, safety standards, what ends up happening? They're capitated for that. A lot of physicians can't afford it. Efficiency of staff. Patient privacy information security requirements. Here is a procedure. One of my colleagues, by the way, who's an ophthalmologist, gave me this slide. And he's been in private practice as long as I've been. And when he started in private practice, it was like roughly $1,200 for a cataract. Now, by the way, this is 2013, but now 2013, he gets paid approximately $215 for a cataract. So what does that mean? He's got to do more cataracts. If he's gonna make a living, he's got to do more cataracts. If he does more cataracts, he's going to see more patients. If he sees more patients, there's going to be a likelihood that there's going to be more medical errors. He knows that. So he's in a system that he can't control. And this is just not for cataracts. It's cesarean sections, hysterectomies, colonoscopies, resections, coronary care procedures. This is a provider designation enhancement. This is where the insurance company, by the way, hey, listen, when I first started getting calls from the insurance company, I would come into my office waiting to see an office full of patients. My office manager said, Dr. Griggs, listen, there's insurance carrier on the phone. You got to justify what you're doing. You need authorization. So now, what they do, they listen to the insurance companies, they create tiers of physicians. How do they create those tiers? Depending upon, again, your performance. So what ends up happening, they give you a provider designation. Provider designation, are you a good provider or are you an excellent provider? Excellent providers get their patients out of the hospital quicker, utilize less resources, order less tests. Okay? So you have to be concerned. Hey, listen, where does your physician lie in there? Pre-authorization claim status. This we see all the time. This we see all the time. I must get at least 10 to 15 letters of these every day. And for this, I've got to pull the chart out. I've got to have, my nurses are not, my nurses who for the most part, are responsible. They have to pull the record. I have to pull the chart out. I pull, for the most part, those records that are pertinent to getting that reauthorization. This is what your doctor's office has to do now. Every time he gets, because not everything's approved. Not everything's approved the first time around. So this is what he has. This is what he has to do. This takes time. I have one of my colleagues at the hospital. He does over 600 deliveries a year. He's got a staff of 5 nurses. This is all they do. They're on the phone every day with insurance companies trying to get reimbursement. It's a game. The insurance companies know. What are they trying to do? They're trying to frustrate the physician. They're trying to frustrate the provider. They know, by the way, if you don't jump through the hoops, you're going to lose reimbursement. Physician practice alternative. This, by the way, I think in the not so distant future, you're going to see more and more, for the most part, providers looking to seek for alternative, for the most part, methods of patient care. Physician response is driven by rising overhead expenses. A good practitioner, myself, practiced for 30 years. No incident, no malpractice suits. I was paying $189,000, by the way, 3 years ago for malpractice. That's $47,000 every 3 months. Before, by the way, I can put a dime in my pocket. So, hey, listen, in order to do that, I got to be delivering patients. I can't be sitting home, by the way, on the weekends with my wife and my family. I got to be delivering patients. Like, to drive a system. Now, nobody complains. And when I first came out, this was an issue. When I first came out, I mean, what the malpractice carriers were paying for insurance, I mean, it was ridiculous. I mean, a young guy coming out. I mean, when I first came out, my partner, by the way, I didn't have a very large obstetrical practice. We did mainly GYN. At that time, the insurance carriers were paying for that. For a vaginal hysterectomy, they were paying $10,000 for a vaginal hysterectomy. We were doing anywhere from 8 to 10 a month. Then things change. Now what do you get for a vaginal hysterectomy? Physician gets, if they're lucky, $852. Okay? So physicians they have to jump through hoops to continue practicing. It's frustrating. It's annoying. Physicians now are either opted out or sometimes they're forced to leave practice entirely, private practice entirely. Some salary employees in hospital or healthcare. Some physicians are becoming fee-for-service providers only. Then you're going to see a rise in the last one, concierge medicine. I have a couple of colleagues, by the way, who do concierge medicine. How does concierge medicine work? It's more common, by the way, in the city. So there's basically a direct contract between you and your practitioner. So for a set fee, what will happen that entitles you to so many set emergency visits, so many routine visits, and you can see your practitioner at any time. And you, for the most part, you pay your fee directly to your provider. The provider doesn't have to deal, he'll give you the forms, he'll do all the documentation for you, but it eliminates the provider, for the most part, from dealing with third parties. So what does that basically mean for the provider? He's less stressed. He, for the most part, can concentrate more so on patient care. The patients want good outcomes. They want to minimize their out-of-pocket costs, deductibles, co-pays, non-covered services. Most importantly, they want timely and efficient care at the time they need it. Invariably, what we're finding out, patients are caught in the middle of this game between the third-party players, the insurers, the physicians. They're basically caught. Rising deductibles. Everyone who's got an insurance policy. Deductibles, 212% over the last 10 years. And the deductibles, by the way, don't cover, by the way, these deductibles have to be met before your insurance carrier, for the most part, pays the first dime towards your care. When I first started, there was an average deductible was anywhere from $10 to $15 for maybe a routine visit that was $80. So $10 to $15 came from the patient, $65, by the way, came from the insurance company, who paid my bill $80. Now, patients see me. Hey, patients, by the way, cost sharing. So patients, by the way, the deductible is now $25. So now I'm getting $55 in insurance. Patients, by the way, don't want to keep coming back. By the way, they know they got a deductible of $25. They don't want to keep coming back to see you. It's $25. $25 is a lot of money to a lot of people. Prescription drug denial. A lot of patients. This is where they deny, by the way, hey, listen, what you need to get better, your prescriptions. The insurance payers, they've already determined what drugs, by the way, hey, listen, they're going to cover. And if, for the most part, that drug is not, your physician prescribes a drug, by the way, that's not in their, for the most part, their formulary, he's got to jump through hoops to determine that you need it. What does that mean? Well, maybe it means, by the way, you're going to get a lesser equivalent drug. Maybe it means, by the way, you're going to have a little bit more pain. Maybe it means you're not going to get as better quickly. Maybe it means, by the way, you're not going to go back to work as soon. But this is what your doctor has to do. He's got to get on the phone. Most of the time, they don't even talk to practitioners. Most of the time, by the way, it's an automated system. So he puts in, by the way, information. He's got to wait. He's got to wait for the most part for like 2 to 3 days to determine whether or not, hey, listen, you're going to get approved for that drug. Limited approval services. Okay, so they for the most part approve services. You want the patient, by the way, to have ambulatory care or rehab services for 3 weeks. They're only going to approve for 2 weeks. So now the doctor's got to redo the entire cycle all over again. He's got to resubmit that information. Of course, they're hoping, by the way, hey, listen, either you just don't pursue it, hopefully the patient gets better, but either you don't pursue it. Saves money for the insurance company. You have to ask yourself, are quality measures good or bad for providers and consumers? Both yes and no. Maintains transparency. Keeps, by the way, hey, listen, the system transparent. What you have this condition, you're going to get this set of treatment. Promotes standardized care across all patient levels. It compels improvements in quality in every healthcare transaction between the patient and their provider. No, participants and the participants don't have any influence on the system. As physicians, as consumers, we don't really have much influence on the system. Third-party payers are dictating, for the most part, hey, listen, what we do, how we do. Providers lose their sense of independent practice. That's the one thing, by the way, hey, listen, being in private practice, you have autonomy. Autonomy is important for a lot of people to do well. Patients are subject to what they call a trickle-down effect between the provider and the payer. How do we keep quality in every healthcare encounter? This is something, by the way, that for both patients and providers. Come to visits prepared with pointed questions. Your provider, by the way, may have a limited amount of time for the most part, and he's got 15 minutes for your encounter. So you want to ask vital questions. Inform the caregivers of any and all relevant internal history. Anything that's happened, by the way, since you last saw your partner, since you last saw your physician. Become an engaged partner. A patient who's engaged, by the way, in their care, the patient's going to do better. A patient who's going to, by the way, seek preventative care much earlier. Providers, and of course, we're all guilty. Provide increased access to patients. There's nothing worse, by the way, than when a patient needs to see a doctor and they can't. Call the number, or they're seeing someone else. Strategize care between low complex, high complex patients. Low complex patients who have minimal, for the most part, disease process, they want fast, streamlined care. Patients who have high complex, patients with high complexity problem, those are the patients who will need more encounters, by the way, in the system. Treat the patient and not the record. I think that's what, for the most part. We're practitioners, where sometimes we go wrong. Where should our healthcare dollars go? Best bet, promotion of preventive care. Not only the chronic disease reduction. Patient educating support service. Patients are educated and receive the support more likely, by the way, to get into the healthcare system much earlier. Medical education and training. New generation of healthcare providers. They're going to have more complex tests. At the same time, they're going to have enhanced technology at their disposal. Pharmaceuticals develop better, most likely to develop more affordable medicines. Research. What else? So at the beginning of the lecture, you kind of, for the most part, said, what is quality healthcare? Quality healthcare provides the right care in real time when the patient needs it in an affordable, safe, and effective manner. It engages and involves the patient, which enables them to take ownership of their care and the treatment of their diagnosed conditions. Engages providers to adopt best practices while simultaneously maintaining a sense of autonomy. Thank you. Any questions? Yes, sir.
This process reminds me of the automotive companies way back in the 90s, where they decided that they were going to reduce the time that it took to develop a vehicle.
Right.
But they didn't change the process. All they did was change the PowerPoint telling you when different stuff was due.
Right.
And it seems like here the medical industry is playing with the result, the cost,
Exactly.
rather than examining the process. And that the underlying changes that would make fewer mistakes. I mean, the bottom line is you have hospitals everywhere.
Absolutely.
You have similar processes. You should be able to develop best practices.
Absolutely.
And when I read about the medical industry, they're clueless in terms of advanced techniques for developing optimized processes.
Well, there's only, there's only, for the most part, you're saying optimized techniques. They're always going to be.
No, but I'm saying when you take a process, I was playing golf with a malpractice attorney.
Oh.
Okay, and for business, we help optimize processes. What do you do? I explain them what you do.
Exactly.
He says, boy, I'd like to bring you in and have you analyze surgery
Right.
and what you could see. And then he later on called me and said the hospital doesn't want to document that kind of stuff. You know, and so as I look at these hospitals, I mean, the bottom line is the people keeping the score playing the game. I mean, I have elderly parents. The new game is they don't admit you.
Exactly.
Because as soon as you're admitted, you have Medicare rights.
Right.
Until you're admitted, you have no Medicare rights. So they can do whatever they want to do.
Exactly.
And I mean, it's if we had elder care issues for 14 years, and it's just been appalling to see what's happening.
Well, I think you're going to, no matter where you go, you're going to have hospitals who, you know, at different levels of expertise. The Memorial Sloan Kettering, the Cleveland Clinics, the Mayo Clinics, the Baylor Institute of Medicine, by the way, in Texas. All of these, by the way, hospitals, these are expertise, specialty type hospitals. They're the ones who are going to have the most complex, integrated, technologically driven, for the most part, procedures, physicians, specialists. And then you're going to have all the outliers. I think the only way, for the most part, for patients, consumers of medicine, consumers of healthcare, is they have to do their research. They have to do their research, you know.
But a lot of the stuff is simple. I mean, because of what I learned about hospitals, the first thing I do when I go in a hospital is I find a JCO violation. And I let them know I have one.
Absolutely.
And I let them know what my background is.
Exactly.
And then my parents get great care.
Oh, absolutely.
Okay, so a lot of these things are not new technology. I mean, it's not fancy new technology.
Right.
Washing your hands, you know. I mean, just, you know, just you can walk. I can walk in 5 minutes. I can find 5 JCO violations in any hospital. So how much does infection cost? I mean, I've had multiple parents who caught infections when they were in hospitals. I'm not talking about the advanced technologies.
Right.
I'm talking about
basics.
everyday, basic, fundamental business practices that should be followed in hospitals, and they're not.
Absolutely. I can tell you, my hospital itself, hey, listen, you know, all employees, physicians, administrators, hey, listen, they have to go through these compliance programs. These compliance programs have to be signed off, have to be filed. And by the way, they encourage, by the way, people to actively, for the most part, hey, listen, to report, for the most part, people who break these violations. Because, hey, listen, don't forget, the hospital is insured by one large umbrella. So if for the most part, hey, listen, we're getting, for the most part, deficits in care, that's going to affect the bottom line.
I had heard this, and I can't say I really believe it. What I heard is that hospitals don't mind if you get an infection because it may mean another day of care and another day of income for them.
No. No. Hospitals, by the way, want you to get out as soon as possible. They want to minimize the infection. They want to minimize, by the way. So what do? Hey, listen, you know, they get you up earlier. They, for the most part, give you antibiotics for a short period of time. They track, by the way, hey, listen, your white count, your CBC, your differential. Once you meet certain criteria, hey, listen, you're out of the hospital. All right. Yes, sir.
First of all, I know you don't remember me, probably don't remember my wife, but 22 years ago, last month, you actually delivered my son.
How do you like that? First of all, you know something? Oddly enough, hey, listen, I get that all the time, and I always ask, by the way, is the baby okay?
Yeah.
Then I can claim the baby. Okay, good. Very good.
Actually, this past May, he graduated from Hofstra University.
Good. Listen, I have a 26-year-old, by the way, who's in law school, and I have a 22-year-old who's actually a 4th year, by the way, at Hofstra.
So I've had my own adventures since last December. I had my right calf was full of DVT. It broke off, and I ended up with extensive bilateral pulmonary embolisms, and was, as I'm told, a couple of days from probably not being breathing. This past August, my health insurance, and I'm sitting here nodding along as you're going through all these, because in August, my insurance company denied me Lovenox, which further put my health at risk for a total of $1,035.66. My health insurance company was essentially willing to let me die.
Right.
With 30 to 40 million people without health insurance
Right.
in this country, and even those with health insurance
Sure.
having these horrible outcomes, the big debate as we head into 2020 is universal health care.
Sure.
Do you think, without getting too political, that some of these costs and some of these outcomes will improve if everybody had access to earlier preventive care and more access to the system?
Okay. Personally, this is how I feel. Hey, listen, I think it depends. I think how individual physicians feel about this depends upon their background, where they came from, why they went into medicine. I personally went into medicine, by the way, to help people. Fortunately enough, I was able to practice, by the way, it was at a very good time in medicine, and I've seen where it, for the most part, went toward the other side. For me personally, hey, listen, I believe, hey, listen, the best case, and I was arguing with my wife last night about this last night. She says, Bob, the right to health care is not a given in this country, okay? It's considered a privilege. A country that's so, for the most part, industrialized and organized, it just doesn't seem right. And again, having a mother-in-law who's now, for the most part, dealing with Alzheimer's, dementia, getting her drugs, you know, you really get to see finally what it's like. I think the best thing that I could give, if you really want to see what's important, try caring for an elderly parent. Then it kind of opens your eyes and it gives you clarity about what's really important. Now, I personally think, hey, listen, you know, healthcare coverage, by the way, should be affordable for everybody. You know, patients shouldn't hopefully get denied. Any questions?